Welcome to the CanMed Coffee Talk podcast, where we talk with the leading minds in cannabis science, medicine, cultivation, and safety testing. I am your host, Ben Amaralt. I'm the Senior Marketing Manager at Medicinal Genomics and proud member of the team that puts on the CanMed Summit. All right, the CanMed 25 abstract submission portal is now open and will be until November 15th. So, if you have done any novel research in the areas of cannabis science, medicine, cultivation, or safety testing, we want to hear from you. If your abstract is accepted by our advisory board, you will receive a 50% discount on the CanMed 25 full summit package, which includes 3 nights at the Wyndham Grand Rainforest Beach and Resort with all the associated amenities, full access to the CanMed Medical Practicum, industry workshops, oral and poster presentations, and networking events, and all-inclusive meals, which include a welcome reception, lunches, and themed beach dinners. Not only will you get to present your work on the stage at CanMed 25, but a video recording of your presentation will be added to the CanMed archive and the Medicinal Genomics YouTube page for additional exposure after the event. And let me tell you, more than one of our CanMed videos have reached up to 6 figures in views. Use the link in the show description to submit your abstract today, or go to canmedevents.com and click the button. Our guests today are Megan Mbengue and Codi Peterson. Megan is the revolutionary force behind Trusted Canna Nurse. With over 10 years of nursing experience in diverse fields like oncology, labor delivery, and hospice care, she brings a unique perspective to her practice. She also holds national certifications in 3 nursing specialties and a Master of Science degree in Medical Cannabis Therapeutics. Codi is the Chief Science Officer at the Cannigma and a practicing pharmacist with a passion for cannabis-based medicine. Given his diverse pediatric pharmacy experience and knack for educating, Codi aims to educate as many people as possible about the medicinal potential of cannabis. Codi and Megan have launched a new IRB-approved survey through the University of California that aims to better understand the signs, symptoms, and challenges of cannabinoid hyperemesis syndrome. They want to understand the key indicators of this condition, hear about any remedies that work, and learn more about navigating healthcare as a CHS patient. If you or someone you know has suffered from CHS and are over 18, please take a moment to fill out their survey. Not only will you be helping this vital research, but participants will be entered into a drawing to win one of 3 $100 gift cards. I've put a link in the show description so it's easy to find. During our conversation, we discuss an overview of CHS symptoms, early symptoms and a prodrome phase, clinical experiences treating CHS patients, the potential causes of CHS, challenges in diagnosing, and treatment and abstinence from cannabis. Before we get to my conversation with Megan and Codi, I'd like to thank this episode's sponsor, Trusted Canna Nurse. Trusted Canna Nurse was founded by Megan Mbengue and Ariane Williams, 2 nurses who are dedicated to bridging the gap between traditional medicine and the world of cannabis and psychedelics. They specialize in creating evidence-based treatment plans for all ages that address chronic illnesses, treatment-resistant conditions, mental health, autism, and more. Learn more at trustedcannanurse.com. Okay, and without any further ado, please enjoy my conversation with Megan Mbengue and Codi Peterson. Good morning, Megan and Codi. Thanks so much for joining me on the podcast.
Morning.
Thanks for having us.
All right. Well, I'm excited to talk to you both about the mysterious cannabinoid hyperemesis syndrome. Longtime listeners of the podcast, or perhaps people who have checked out the CanMed archive, may be familiar with CHS. We've done a couple episodes on it, and I know that Ethan Russo presented at CanMed 24 about some of the research that he's done. But really, the first time we discussed it at CanMed was back in 2019. And if I remember correctly, we actually kind of had a hard time filling that panel because the topic was still very new and not a lot of people knew about it. But, since then, awareness has increased, but there are still a lot more questions than answers when it comes to CHS. So I'm thrilled that you guys are doing the good work to try to better understand this condition. But with that said, I always like to start with the basics for folks who might not be familiar with the topic. So, Codi, would you please summarize CHS, what we do know about it?
Yeah, and thanks again, Ben, for the complimentary words. There's a lot of people talking about this topic because it's increasingly important because more and more patients are showing up with this collection of symptoms. And really, it's kind of a pretty simple list of symptoms. It's uncontrollable nausea, vomiting, episodes of that. So this lasting for hours or even days. And we see this associated with someone who's using cannabis very regularly, oftentimes daily or more. And these are refractory vomiting condition that does not respond to normal antiemetics, but is often relieved by a somewhat peculiar phenomenon that is hot showers or bathing. And talking very hot, in these showers, the only time they're getting relief from this very intense nausea feeling. And sort of that little collection, believe it or not, is the vast majority of what we know or what we're trying to call CHS. But there's a lot of questions around that as well. But definitely repeating episodes of intense nausea and vomiting doesn't respond to other medicine. Patients who consume cannabis and might be relieved with hot baths.
Great. Megan, anything to add there?
We'll get into it.
All right, very good.
All the things I have to add.
Cool. And so kind of before we get into, the different things that we're curious about or, that we're trying to uncover with CHS, I was curious about the two of you being clinicians, your experience dealing with patients who are kind of suffering from this. So yeah, let's talk about that. And Megan, maybe you can start there. Like, have you worked with patients suffering from CHS, and sort of what are those cases maybe have in common, or what's unique in what you've seen?
Yeah. Before we get into that, we'll plug the study real quick that we are recruiting right now for our CHS survey, where it's a 2-part survey where people will answer detailed questions on their CHS symptoms and their cannabis use history. So I don't know where we're going to post the link, but we're recruiting for that.
It'll be in multiple places. We're gonna.
It'll be all over the place.
Yeah, I'll definitely put it in the show description for this episode too, so people can easily find it.
Perfect. Thank you. So what I see, oftentimes I see people in the early stages of CHS in what's called the prodrome phase, which is phase 1 of CHS. And this is a phase that can last for months, years, maybe even a decade or two. And common symptoms of prodrome are waking up with morning nausea, anxiety, like kind of GI upset, heartburn, just not feeling well. And alcohol intolerance is one that that's a surprising early symptom, but very common among CHS patients. And so I get those people a lot that say that they have these symptoms, and oftentimes cannabis can help these symptoms. They wake up feeling nauseous, they use their THC, and then they feel better for a limited amount of time. And then eventually this rolls into the hyperemetic phase, and I'll let Codi
we sort of touched on that. That's sort of like what we're characterized with, which is this intense nausea and vomiting. Once again, for no other reason, when you come into the hospital where I see patients in the hyperemetic phase, they're not reaching out to me online, but rather I still work in a traditional hospital setting as a pharmacist. And we're seeing patients come in these intense bouts of vomiting, kind of unaware of this unwellness or the cause of this unwellness that Megan just described for extreme periods of time. And now they come into the hospital, we do what's called a full workup. We scan them, we check every, potential cause of nausea and vomiting, the top 20 most common things that cause vomiting in kids, and none of them they're all clear. You might find a little inflammation in the belly or something like that, but generally almost nothing. And sometimes if they don't say anything about their THC use. We don't even know, right? Because we didn't do a urine screen. We weren't looking for it. This, again, I deal with kids, so they're under 18, so they might not be honest. Let's be honest. Adults are also not telling their doctors about their cannabis use. And so they go undiagnosed. And so we frequently see this with patients with CHS as well, as they get into this hyperemesis phase, they kind of recover, they fall back into this unwellness. Maybe they have a GI doctor, they're in the healthcare system, but we don't know. And then they bounce back in this intense vomiting, the right person or the right doctor or the right lab, those sort of three things align, and there's a light bulb moment, like, this is probably cannabis. And I see this with some frequency. I mean, look, I saw a patient definitively with this condition last 2 nights ago in the hospital. And then last night I was asked to come check out a patient and assess whether they had CHS, and it looked like probably not. And so like there are times where this isn't the diagnosis, but I'm seeing this more and more in person myself, who's a big skeptic, a huge proponent of cannabis. I'm not trying to demean the plant or raise alarm bells, but the cannabis products, whether it's the THC itself or something else in these products, is causing this syndrome, this collection of symptoms in an increasing amount of people. American citizens, our friends smoking legal weed potentially, are getting sick. Why?
No, and you touched on a good point. The amount of cases are growing. Is that just because of a better awareness? We're better able to identify it, or is it potentially something else?
There's evidence to say that well into the knowing about this disease, like 2005 is when it was first described. Now this was actually first described in Australia by a doctor who noticed this in these patients who had been consuming a lot of cannabis. Word kind of slowly spread, and we've seen more and more. There's still a lot of lack of awareness, and there's still a lot of stigma. So we're seeing both sides of the coin of overdiagnosing and underdiagnosing, lack of awareness or lack of sharing, right? It's all kind of swirling to make a bad situation for patients who are just really trying to understand why they're sick. And most of them have no idea that it's their cannabis, which they believe to be highly medicinal and have very little negative effect. And that is the case for the vast majority of our patients. But for some reason, and Ethan Russo, you kind of alluded to, maybe for genetic reasons, there seems to be some patients who just cannot tolerate cannabis in large doses over long periods of time. We don't fully understand why yet.
Excellent. No, and I was glad that you brought it up, Megan, about sort of these early warning signs of CHS. And it seems like you've described them. So when patients come to you with that, sort of what is your advice or a way to sort of prevent them from getting to the hyperemetic stage?
Well, first I ask a lot of questions on what does their use look like? How long have they been using? Tell me more about your symptoms and what you're feeling and what you're experiencing. And a lot of them have like almost textbook exact same stories. They've been using for a long time. They wake up with morning nausea. Cannabis helps a little bit, in the interim.
They've seen 10 different doctors. They've been treating with 3 different GI medicines. Like they've done all the scans. They've ruled everything out. No one seems to know what's actually causing their illness. And it's not just belly pain or the emesis. It's this overall malaise and like the prodromal phase is not fun. People don't feel well, even though they're not in the vomiting phase. So those individuals who haven't figured out that it's the cannabis they're consuming daily or near daily is what most, it seems, have developed it, although there's some variability there that we're trying to tease apart in our study. Like, how often are individuals developing this consuming? Is it once a week, or does it seem like everybody's consuming multiple times a day? Are they smoking high CBD flower, or is it mostly high THC products? Are you getting your products in the dispensary, or are you growing your own? And there's so many questions that we don't have at least even like weight to, right? It's just sort of opinion that we've heard on the internet. And so we were really trying to put some weight to that and help guide doctors and inform patients about what could be going on with them.
And I think one of the really interesting nuances of this syndrome is that it's not is how the THC can help in the interim, but it's when patients get towards, not consuming, they've like, maybe that's because they've either been sleeping or they go on vacation. And that's when the symptoms tend to start to rev up and they start to have like the nausea, the GI distress. Codi, what else do we see? But we see that in oftentimes like days 2 to 3 of abstinence from cannabis, which kind of that rebuts the whole neem oil pesticide thing, that like in the absence of that, we're seeing these symptoms.
I would say the other two things that are pretty commonly seen, and yes, sometimes in the morning, not exclusively by any means, are in thermodysregulation, which is a fancy way of saying my temperature's fluctuating a lot. I feel hot and cold. I'm sweaty. I'm flush, but not being able to regulate that normally. And intense anxiety, abnormal anxiety. You're kind of like your heart's already racing in the morning and you're already doom and gloom and stressed about your day, but you're just started. And that's not normal for you. Some individuals that is actually just their norm. But when it's not, then this is another, I think, kind of low level dysregulation alarm that I would call most of what Megan has described in the prodrome. And again, that's speculation. We don't fully understand the condition, but we know there's a dysregulation. We see these cycles of nausea and vomiting. We know there is a weight being put on the scale, which is a cannabis product. Again, usually, as far as we know, high THC cannabis products. And trying to figure out how, when we push on that scale, it all comes out to this vomiting condition we're trying to pick apart. And there are theories that it's not the THC, by the way. Have you heard one?
Yeah,
Ben,
I have heard them.
What's the one you've heard the most, Ben?
Pesticides, neem oil.
Pesticides, neem oil specifically, right? First of all, I would say for a lot of weed people, we like natural things, right? Neem oil is extremely natural. It is it is the actual oil from a tree nut. And so a tree, maybe just the tree pulp, but either way, from the neem tree. There's not a lot of evidence here. Ethan Russo very definitively, puts his line in the sand here and says, this doesn't look like, and I'm going to mispronounce the active ingredient in neem, but this doesn't look like that toxicity. And when I talk to, toxicologists and emergency physicians who I work with closely, it doesn't really look like acute pesticide toxicity in almost all the forms in which we know, because the response to the toxin is not immediate, which is almost always the case, especially if you're smoking it. So, it would be very weird to have repeating episodes in this cyclical nature every couple months, and that is correlated with potentially your menstrual cycle or stressful events or whether you drink alcohol. It doesn't totally line up with it. I wouldn't even say totally. It doesn't line up with a traditional toxidrome, which is in being intoxicated by a substance or being having that poison in your body. So, there's a lot of reasons it doesn't look like neem, but I'm open-minded. There could definitely be an increasing amount of pesticides in our cannabis, and we need to study that. But it would be a little naive to call it pesticides when we know some patients smoking what is presumed to be clean cannabis. So there's an argument to be made about what the definition of clean is, but legally purchased, regulated cannabis who are still developing CHS. Right. So then if I look at what's in that product, and I can definitively say there's not very much of any of this other stuff, but there seems to be a lot of one particular thing. That thing is THC, and it tends to be the warmest, in a doctor's like, that's probably the thing that's causing it. The thing that exists in 30%, not less than 0.05%, because it's under the detectable limit.
Right. Occam's razor, right? I mean, the most logical explanation is typically the right one.
Yeah, and I want to point out, so my expertise is in the endocannabinoid system. I love this system. I'm doing a talk on it, 2 of them in the next 2 months at either MJ Unpacked in Missouri or at Society of Cannabis Clinicians in Baltimore. I love this system. This system is homeostatic regulatory system, connecting all of the other systems in the body, including the adrenal system, which we know is disrupted in the ECS, including your thermoregulatory system, which we know is it's related to your GI motility, it's related to your pain sensitization, it's related to your, again, heat sensitization, your hot baths and hot shower complex. We can explain away, without even much of a stretch, how THC interacting with CB1 receptors could dysregulate, well, not just CB1, but the endocannabinoid system could dysregulate in a way that could explain almost all of this. And so for me, that is the warmest theory, but we need real science. This is a theory, and a loose one at best. It's not even a hypothesis, or maybe it's a hypothesis and not a theory. Either way, it's the lowest one. But we need to do this work, and we need to start with asking the right questions. And the right question is this what pesticide toxicity looks like? And the answer is almost a resounding no, especially when you consider the hot baths. I haven't seen anybody get exposed to organophosphates at a farm in, Sacramento, where they rush into the hospital and place into a warm bath.
Yeah. No, and you kind of touched on other, hyperemetic type of conditions that may sometimes be misdiagnosed as CHS. But so I'm curious, in those cases, are the hot baths helpful for other sort of similar conditions, or is that very much unique to CHS?
It wouldn't use the word very much. Do you want to take it, Megan?
Sure. I had to do this as part of a program or a part of a project in grad school. So, their CVS is like the umbrella. CHS is a subset.
Cyclic vomiting syndrome is the big term for conditions like this. And then CHS is a subsection within that.
Right. And with CVS, oftentimes that's not related to cannabis use. Oftentimes it's related to childhood stressors or traumas. And that's how the stress manifests in kids and teens is cyclic vomiting. And THC cannabis helps those with CVS, and it doesn't make it worse. And that's a big differentiating factor. There is some evidence that hot showers can help those with CVS, but it is predominantly it's CHS. It's one of the pillars of the syndrome itself.
So yeah, I think just to circle back and I guess rephrase, because I agree. So you've got hot baths and showers. It's not common that people would do that for nausea, vomiting, but it's not also unheard of. You feel unwell, you're going to go take a hot bath and feel a little bit better. So just throwing that out there for not even cyclic vomiting. Some people would argue you can feel better from a hot bath. Now, these patients report a significant difference from I want to die, I'm so nauseous, to I can tolerate life on this realm, and it's a big stark difference. But setting that aside, cyclic vomiters, which Megan alluded to, we don't fully understand, but is definitely associated with childhood stressors and traumas. But there's an imbalance or a dysregulation of the systems. Now, those individuals are still hard to treat, but we do treat them with traditional antiemetics. They typically respond more to the Zofrans, the serotonin blockers that we give normally. The other thing is, like Megan said, it's almost all of them will have developed this condition before they started smoking cannabis, because it is a childhood or teen developing, although it can happen in adults too, but I'm trying to speak in generalities. You're going to see it earlier. And these patients often report benefit from THC. But don't forget, Megan mentioned that a lot of patients who develop CHS also get some benefit. And now I've got a patient who's got a cyclic vomiting disorder who smokes cannabis, who says it makes him feel better. Now the doctor's like, oh, this could be CHS, especially if they don't know that patient or know their history very well. So there's a misdiagnosis there. Even though they're not taking hot baths, it's because the THC showed up in their urine. There's a cross confusion. Lastly, I want to say the differentiator around the hot baths. I've seen both. I've seen a paper that suggests, yes, that's a good indicator. And I've seen another paper more recently that suggested actually both cyclic vomiters and cannabinoid hyperemesis sufferers both find some relief from hot baths, which sort of mutes out that as a diagnostic factor, only making the job more challenging, right? Of truly identifying which condition we're dealing with. Is it the weed that's causing the condition, or does this patient have an underlying condition in which weed is helping them, but they have the same vomiting problem. Cyclic vomiters don't typically have prodromal symptoms in the same way that CHSers do. And I think headache, if I recall correctly, is a more common precursor to a cyclic vomiting episode, but it can happen before a CHS episode as well. So it's not a clear picture.
Right. And with the hot bathing too, I think with CHS, it's labeled as like pathological hot bathing. Like people will burn their skin, get second, third degree burns on their skin from needing to be in the scalding hot showers for long periods of time.
Yeah.
Wow. Yikes.
I know.
Yeah, we've seen some pretty severe cases. You know, the average person isn't doing that, but they will rack up a $500 gas bill or, you know, water bill, and they just run the water all day long. Parents will be like, we cannot get him out of the bath. Like, he won't come out in the morning. We're late for school, like all the things because of the showers.
And now, is total abstinence from THC a solution?
I would say it is the textbook solution. How, in your experience, with abstinence, how do you people do?
Can be difficult.
It leaves some to be desired, right? Megan, have you ever seen, I'm sure you've seen patients go abstinent, but have you ever seen anybody, you know, not go abstinent?
I mean, all the time, people continue to use.
Often not believing their diagnosis.
Right. Or that they feel like they can still continue to use low amounts and manage their symptoms that way. But for that is interestingly, like one of the only published criteria for CHS is, you know, that if your symptoms go away after 6 months of abstinence, then it's likely that you had CHS 6 months ago. So, but it is, you know, if it's like the presumed cause, then taking away the cause is likely going to be the solution. And I think that for some reason that pisses a lot of people off. Like, we're actually getting at the root cause of this, and they're like, there's no cure for it. Well, you take away the cause of it, which is, that's an interesting, you know, paradigm that I see. But yeah, it's, that really is the only known thing to help with CHS. And recovery is a roller coaster. It's not like you stop using and then your symptoms go away. And, you know, stopping use can then trigger episodes down the line. And people are using their cannabis to stop an episode from happening, and then they stop using, and then it triggers an episode. Or they have stopped using for a couple of months, and then they eat some food that triggers them, or alcohol or a stressful event triggers a CHS episode, and they haven't used in 3 months. So recovery.
Now they don't think they have CHS.
Right.
Because this dysregulation or this imbalance sort of lingers in our system for an extended period of time. Patients sometimes reporting 12 months before they feel whole again from a GI perspective. The damage and the inflammation that went on during their, and you know, remember, people suffered for years without knowing, right? There are people on these discussion boards that suffered for 15 years with a condition. They'd seen every doctor, no one knew what it was, right? And they've been taking medicine and had all the scopes and done everything. But how did I get on this point, Megan?
Don't remember.
What you were just talking about.
Recovery.
Recovery being a roller coaster.
Right. So what I always counsel my patients on is, like, you know, patient yesterday hadn't consumed cannabis in 9 days, and she was in the middle of an episode, and it was triggered, you know, at Disneyland from a hot burrito, a birria taco or something of this effect, right? And that's what set her off into this problem. So we don't, you know, we don't fully know what the timeline looks like. We're going to ask you questions about this. If you take our survey or you send this to your friend, we're going to ask about how long after you quit did you have symptoms. But I can tell you my personal practice experience, I am not a CHS sufferer, but in my experience talking to patients that have it, we're seeing easily 7 days, usually 21 to 30 days, and sometimes 60 plus days of, oh, I just had an episode again. Don't know what it was. didn't know, maybe it was stress, like Megan said, maybe it was some weird food that you thought you could try again because it made you sick a long time ago, but it happened. We don't know, but we're trying to put that together so we can use that to educate patients, to help them know, because physicians aren't telling patients to, I shouldn't say any, most physicians are not telling folks that, hey, you might have more vomiting over the next few days. You should expect to have more vomiting over the next few days, even though I believe you and you quit 3 days ago. And that conversation is not happening because physicians aren't aware enough, or frankly, the data doesn't help them right now. There's not a lot of evidence for them to lean on and say, oh yeah, most patients will have another episode in the next 21 days. They don't have that information. So that's what, again, the survey is trying to give them some info to lean on to more quickly and definitively know sort of how to categorize and then how to treat, as opposed to throwing a label on something, throwing an antipsychotic to help get them out of the emergency room and sending people on their merry way, which unfortunately happens more often than not.
Yeah. No, that's new to me. Like I said, I've done a few episodes on this and seen some CanMed talks on it, and obviously seen other things. I didn't realize that the roller coaster of recovery there. I thought, you abstain, your symptoms go away. It's really interesting that other things can sort of trigger it. And I mean, not that I'm a clinician, but my thought with that, and you could tell me if I'm on the right track, is, other things are interfacing with the endocannabinoid system, not just cannabinoids, and other things can kind of cause spikes in your endocannabinoids. So do you think that's perhaps what's going on? Like certain stressors, triggers can sort of just dysregulate
I'll
that
hit
system.
on one point of that, is that oftentimes people in recovery, some people will exercise and work out, and then sometimes that can trigger symptoms. And, we know what exercise does to our ECS. So some people are told to exercise, but don't go overboard because you don't want to trigger anything. Codi, go ahead.
Yeah, and we know that part of the endocannabinoid system's role is to chase the circadian rhythm, and we're seeing this weird sort of morning presentation. Once again, there's not good data on how many people are having this morning. It is mentioned in the literature, but how many is unclear. So we're hoping to get some hands on that. But the ECS naturally follows the cortisol level. So as cortisol comes up, the ECS comes up and turns it off. Okay, but if your ECS isn't working and the cortisol is running out of control, and now you've got this sort of imbalance. We see this almost every day, I guess, is what I'm getting at, on a micro scale. On a macro scale, yeah, some women are reporting their menstrual periods, which we know there's a dramatic shift in endocannabinoids and function throughout the body and the reproductive tract. Just like so many, again, like ways to kind of tease it together. I do think there are things we can do outside of THC, right, that interact with our ECS. But very few are as powerful of a hack as sucking down the plant medicine out of a battery 18 times a day. And, I don't think no amount of meditation will be able to sort of replicate that sort of stimulus to the system. And so, I still tend to lean towards yes, there are things that happen, but the ECS is highly dynamic and it's working real hard, even when you smoke weed all day, to keep you in balance, in check, awake when you're supposed to be, sleeping when you're not, etc. And so if it just doesn't have the muster, and that's maybe what's leading to this dysregulation, sort of a suppression of the natural ECS because of too many phytocannabinoids, then it seems pretty obvious that treatment would then lean towards trying to restore balance without the introduction of that phytocannabinoid, this very powerful modulator of this system. So back to, and I wanted to finish where Megan was going, and I'm so glad I just remembered, is to what cannabis can you use, right? Abstinence is, look, I tell all my patients, the textbook answer is you got to quit. And the truth is, you definitely have to quit. For now, I don't know what the future holds for you. I can assure you what you're doing right now, you don't get to do this again. Like you don't get to go and just consume cannabis willy-nilly like it doesn't have an effect on you. We now know you're, for lack of, or just using poor terms, a carrier, right? Of you have this genetic makeup, you have this disposition, And therefore, if and when you decide to go back to cannabis, know that this is a risk. What you're dealing with right now is a very much a risk. And you're going to need to be aware of it. Because remember those symptoms that you had 5-6 days ago? That was your body telling you that we got a problem and you didn't listen. Or just as an example. But, I think there's a conversation to be had that is, there's a risk and therefore you shouldn't do it. It'd be like somebody who contracted an STD and you told them, hey, no more sex for you, buddy. That stuff's dangerous, right? And instead of teaching them mitigation factors, acknowledging that we're humans and potentially that person was deriving substantial medical benefit from cannabis medicine. And that's where they started, right? They didn't just start consuming cannabis all day because they were bored. I mean, I'm sure there's a couple examples that most people are using it because they're anxious, because they're dealing with pain, because they're dealing with the stressors of this crazy, modern world we live in. So, to deny them of any cannabis medicine is challenging. And I think that there might be hope for other cannabinoids as well. And if you're listening and you have CHS or you're hearing about this, we want to hear about what you've tried that works. What did you change to? What has not set you off? Because we know people are doing this. I'm willing to bet, and I hope the data shows this, probably half are floating this like, I don't fully accept, or I know that I have CHS, but I still smoke on occasion. We got some people who've gone hard, they develop CHS and they discover mushrooms and they're like, holy cow, I can't believe how cannabis wasn't serving me. Like, we see this whole spectrum of experiences among these sufferers, and we really just want to catalog them and document them. So thanks for having us on to talk about it.
Yeah, absolutely. And I did want to sort of talk, so we talked about the contaminants and, whether or not that's a factor.
The causative factor. I believe there are contaminants in cannabis.
Sure.
I believe they can cause certain illnesses. I'm just not convinced that this collection of symptoms that we're talking about here today is that. I think people are getting sick from contaminants, whether it's in hemp converted products or whether it's in pesticide-ridden legal products that are even in regulated markets. That's just not what I'm talking about. I'm talking about this very specific set of symptoms of hyperemesis and prodrome that doesn't line up with a typical toxidrome.
Right. So it's much more likely that this is a cause of high doses of THC, correct? So talk a bit about what patterns you've seen in terms of like, what's the route of administration? Like, are these people consuming concentrates versus flower, edibles? What does that look like?
Have you seen any studies on this, Megan? Like, have you?
I have not seen studies, but I do have lots of anecdotes of people who come to me. And this is exactly what this survey is for, is to tease this apart. But the people who come to me will say either I've been smoking for a decade or 2 or 3 or 5, usually smoking flower, or I've been using concentrates for a much shorter period of time. That's what I have seen. And then they start to develop those.
So like 6 months, 1 year, 2 years for concentrates, as opposed to this decade that you feel like most of your patients. Megan and I have talked about this, so I kind of knew what she was.
Right. And it's interesting that in teens, Codi has worked with more teens than I have, but the few teens that I have seen has been like a short period of time of using concentrates, like 2 to 3 months of using concentrates, go on vacation, and then start to have CHS-like symptoms with the prodrome in there too.
Yeah, that sounds shorter than average. Not denying that it happened. I think, that individual may be more predisposed from a genetic perspective. Mm-hmm. We know that there's at least 6 mutations that Ethan was able to identify, just in his preliminary, relatively small studies. So we're going to learn more as well. I think what we've seen in data, so I'm trying to reach back, in 2019, you had Alice Moon on in your guest. I was in 2021. I was my class president at U Maryland. We did a online education on CHS, and we had Alice as our guest. Alice was able to present her survey data that she had done, which ended up not ever being published. I think she recently collaborated on a new study that should be published soon out of UCLA, looking very similar to what we're doing, which is great because we got to get more data. We need to help. We need to help. And one study's nothing. Like, we need robust decision support. So What I'm getting at is Alice shared her data back then with me. And when she showed us, she did show that the majority of consumers had been smoking greater than 3 years, sorry, inhaling cannabis for greater than 3 years. And there was a mixed collection, the vapors, dabbers, and the smokers, they all had sort of developed it, but very few had been edible only people. Very, even less had been CBD people. There's a couple other distinctions in her data that were interesting, but that's the one that comes to mind. It was very clear in her data, collected from like 200 or 300 patients that she personally interviewed because she was afflicted by this condition and no one was doing this work. So every time someone would express to her that she had CHS, she would send them her survey. She would collect that data, and it was enough to kick Alice off as to be a powerful voice and advocate in this space, which I'm happy she's able to be. She's taken a lot of kicks and jabs for her role, and I think that's representative of the stigma that the community gives off to many patients afflicted. Patients don't want to share that they've developed an intolerance to the medicine that they loved, and also that their friends consume every day, and their friends would not understand or say they're making it up or tell them that it's not what it is. It's neem oil. You're smoking the wrong weed. There's all these things. The stigma's real, and we're trying to measure that in the study too.
Yeah, no.
You can see I'm getting excited. We're pushing it out like this week, y'all. If you're listening to this survey, we're pushing it out, which is great. This thing has been, I don't want to say a thorn in my side. It's been my baby, but this thing needs to fly.
Yeah, so talk more about the study. So if people are listening here and they're curious about whether or not they're a good fit or who you're looking for, talk about, who should be participating.
Yeah, so Megan, me, our principal investigator, Dr. Ariana Nelson at UCI, where this study has been submitted and approved through their IRB. We are looking specifically for just really simply two criteria, basically. Are you an adult? We need 18 or older. There's just too much complexity in trying to get this info from kids. Hopefully we can start to uncover more about pediatrics later. So we need you to be an adult who either has been diagnosed with CHS or believes they're suffering with CHS, right? We don't need you to be diagnosed by a doctor, but we need you to kind of think like, this is what I'm pretty sure what's going on. And we got a litany of questions, right? It's 2 parts. Each part's going to take about 25 minutes. It's a long time, I do recognize, but to make it more valuable for you, you will be entered when you complete the survey into a raffle for a $100 gift card. We're leaning towards Amazon, but not to brand drop. But we're still figuring out where that's gonna come from. But yeah, we're really excited to drop this 2-part survey to understand both the symptoms and use patterns, and then also the burden. How much healthcare, how hard has this been on you and your family? And the truth is, it's gonna be.
What organs did you have removed?
That's literally a thing, right? Did someone cut out your appendix during the process of trying to discover that all of this inflammation was because your endocannabinoid system was out of balance because you've been smoking too much cannabis or marijuana, as they say.
And now, so we talked about before, sort of that early stage prodromal
is the
prodromal.
symptoms, yeah.
Yes. Now, people who are listening to this and think, oh, that kind of sounds like what I'm dealing with. Like, are you interested in those folks too, or only kind of in the later stages?
We're looking for individuals who've experienced hyperemesis, right? Okay. So I understand that they're what Megan and I talked about, which again, we're trying to understand better too as part of the study. But what we talked about is that early sign, and we've seen that. But those are not necessarily the patients we're trying to talk to, because we want to understand more about your hyperemetic phase and what might have changed leading up to it. So for those folks, I would encourage you to go read about cannabinoid hyperemesis syndrome. I would encourage you to go understand it more and not to freak out. I've also had people who are so anxious about developing this, and they don't want to get this because cannabis is so helpful to them. It's unlikely that it's going to happen. But what's the most definitive factor is going to be thoughtful or conscious or mindful cannabis use, as opposed to continuous all day use. And some people need cannabis all day. Some people prefer cannabis all day. Yeah. And in individuals who prefer cannabis all day and develop CHS, the truth of the matter is we probably can't make that decision that way anymore. But I wanted to acknowledge that medical patients very much need, right, to get through their day, CHS. And unfortunately, some of those individuals have developed, CHS as well. And then we got to fight through, how do we,
Right.
switch to pharmaceuticals, or how do we change your cannabinoids to try to do this? So there's a lot to learn. But right now, those who have CHS, or those who believe they have CHS, but that we would look for specifically for people who have had an episode of hyperemesis, just so we can get the most understanding of their path through the hospital system. But yeah, for anybody who's experienced what you just described, those prodromal symptoms, but you're not sure, it would be really reflective on the way cannabis feels. It might be time to take a tolerance break and see how you feel in 5 to 7 days. You might be astounded, right? And so it could be a really, really powerful experience. And if you happen to develop hyperemesis while you try to stop THC, I need you to take my survey.
Yes.
I'm teasing, but seriously, because
Yeah.
this is another one of our leading not leading, but like, this is another idea that we've kicked around as a group. Knowing that we see this sort of withdrawal induced, like, again, it makes sense in the setting of like dysregulation. If it's all out of whack and it's gotten used to having the THC, and then you pull that back, now the system is out of whack again. And so that might be it. But again, that's full speculation.
Right.
Excellent. All right. Well, Codi and Megan, thank you so much for the time. Again, we're going to put the link to the survey in the show description so that people can find it. And, anyone listening, please spread the word. Let people know that this survey is out there and that you should be participating. But before I let you go, I'm going to let you both share any other additional resources around this topic that you think might be useful, and then information about yourself and how folks can maybe get in touch or connect with you.
Yeah, I think one of the fascinating places to actually learn about this in real time, we get a lot of flack for this, but it's the Facebook groups. It's the online CHS Facebook groups where you get real-time anecdotes from people and their experience. And a lot of that has triggered what we are putting in the survey and how we have asked the questions in the survey. So that's a fantastic place for people to not only learn about it as clinicians and cannabis consumers, but to share their experience and get advice from peers on what has helped them, how long their symptoms lasted, because it's so nuanced. So Facebook groups are one. There's one that's called, what is Katie's group called? It's run by a nurse friend and colleague of ours who's working with us on the study.
Safe space.
Yeah, CHS, a safe space to learn. It has a purple, purple on it. And she's a nurse, and she helps people directly, going through their CHS episodes. So that's a fantastic resource.
And trustedcannanurse.com, obviously.
Well, yeah. I mean, we typically refer people out to her if people are wanting to stop the cannabis use and kind of if they need help with that part of it. Then we talked about this last year. This is what we do, the microdosing of psilocybin for, to help them desire cannabis less. But in the immediate hyperemetic phases, that's where Katie is a fantastic resource.
Awesome. Or Katie's part of our study as well. Yeah. She's going to be one of our authors, and is going to help us get this into those communities on Facebook. So first, I want to speak to anyone who listened. Thank you so much for making it this far. I appreciate your time. I know that you may or may not, more than likely, just statistically, you don't have CHS, but you could share this podcast, and you can share our poster, which will be shared in this as well. Come to any of my pages. It would mean a lot. We're trying to get this out here. The more people we talk to, the better data we get, the better we can lead physicians to not make some of these standard mistakes, more we can help patients to understand what to expect. There's so many benefits and really no downside. All you got to do is share. You just got to say, hey, weed is really cool, but it's not perfect. Mm-hmm. You can also call me out. Say, this guy thinks he knows all about this CHS stuff. He doesn't know anything. Go tell him what you really experienced. Tell him it's neem. That's fine too. Share it. Yes. Anyway. Yeah. Other than that, I've got a YouTube video on CHS. If you want to hear more, just sort of like my solo preach, just Google my name, CHS, and you'll find a YouTube video. The other thing is Ethan Russo. We talked about him already. His website, what-is- CHS, is a place where you can purchase a DNA test to see if you have one of these mutations. There's also some facts and a useful resource and education. So you can check that out. And, when we maybe drop the paper, we'll come do another podcast, show up at CanMed, do a whole thing.
Absolutely. We'd love to have you. And yeah, I hope to see you both down at CanMed in June, either talking about this or any of the other great work that you guys are doing. So thanks again for the time, and we'll see you soon.
Thanks for having us.